Hey guys, it is Miss Smith, and today we're going to be talking about cardiovascular medications. We're going to split the cardiovascular medicines into different categories. So the first one that we're going to be talking about is diuretics. So two ways that diuretics work in the body, they help lower blood pressure and they help decrease edema. And the different types of diuretics that we'll talk about is thiazide and thiazide-like diuretics, loop diuretics, and potassium-sparing diuretics. So your thiazide and thiazide-like diuretics, they're going to act on the distal convoluted renal tubule, that's beyond the loop of Henle, to help promote sodium, chloride, and water excretion. So you can see in this picture on the slide, it works right where that arrow is pointing. Some examples are chlorothiazide or Diurel, hydrochlorothiazide or HCTZ, and metolazone or Xeroxilin. Your side effects or adverse effects, the main one's going to be hypokalemia, and you need to watch this with your patients that take digoxin. Because if they have hypokalemia from the diuretic and they're also taking digoxin, this can throw them into digitalis toxicity. And we'll talk more about digitalis toxicity later on in this PowerPoint. And the hypokalemia is from when you take a diuretic and you're getting rid of sodium in the water, you're also getting rid of your potassium. So that can cause the low potassium level. There's also side effects of hypercalcemia, hyperglycemia, so especially with your thiazides because they affect the metabolism of carbohydrates. They can increase levels of cholesterol, so hyperlipidemia. You can also have hypotension, dizziness, vertigo, lightheadedness, and this can all be from the loss of that extra fluid, kind of throws the equilibrium off. Anorexia, GI distress, nausea, vomiting, diarrhea, constipation. So for your thiazides, you want to make sure to take it with food because it can upset the stomach. Next is your loop diuretics, and these act on the ascending loop of Henle, and it inhibits the reabsorption of sodium, so it stops the body from reabsorbing that sodium. And then wherever sodium goes, water goes, so sodium and water are lost, and along with potassium, calcium, and magnesium. Loop diuretics are going to be the diuretic that has the greatest diuretic effect, so be careful with your patients that are taking loop diuretics. Some examples are furosemide or Lasix, bumetanide or Bumex, or torsemide or Demodex. Some side and adverse effects, again, hypokalemia because you're losing that potassium, and watch that when your patient is also taking digoxin because it can throw them into digitalis toxicity. Anorexia, nausea, and vomiting, so make sure that they are taking the loop diuretic with food. Autotoxicity, and this is especially true for your Lasix. A lot of the times, if you're in acute care, you might have to give Lasix IV or furosemide IV, they're the same thing. So make sure that you administer it slowly because if you administer it too fast, it can cause autotoxicity and some hearing loss. Postural or orthostatic hypotension, and this is from all that fluid loss, so make sure you're telling them to rise slowly from a sitting to standing position. Dizziness, photosensitivity, and this is not just like lights, it's also with the sun, so make sure that when they go outside, they're using sunblock and they're avoiding long exposures in the sun. They can also have fever and chills and anxiety and confusion. With your loop diuretics, they might also be prescribed potassium supplements because you get rid of that potassium so much, and you don't want to throw them into hypokalemia. So it's usual to see a patient prescribed a loop diuretic and a potassium supplement to go along with it. And also consider if they have a sulfa allergy, if Lasix or a loop diuretic is the best idea for them. Here is a little picture for you guys if you are visual learners. So this talks about furosemide, and then it's also known as Lasix, and that is because you can see it lasts 6 hours. So Lasix lasts 6. That's just some way that you can remember how long it lasts in the body. If you take it orally, it can cause diuresis 30 to 60 minutes after ingestion, because that's usually how long it takes for it to be absorbed in the body through the GI tract. IV usually starts in 2 to 5 minutes. It's going to peak in 30 minutes and kind of decrease after that 2 hours. Down here on the bottom left, it shows you the side effects. So low blood pressure because you're getting rid of all that fluid. Photosensitivity, so watch with the sun. It can increase blood glucose levels and it will decrease those potassium levels. So this is just a way that you guys can, this can help you guys remember furosemide or Lasix or loop diuretics. Next is potassium sparing diuretics. So this is essentially exactly what it says. It keeps the potassium in the body. So this acts in the collecting duct, renal tubules, and late distal tubule to promote sodium and water excretion and potassium retention. So this is kind of the opposite of your thiazide and loop diuretics, because the loop and the thiazide, you have the risk of hypokalemia, getting rid of too much potassium. But for this one, you have the side effect of keeping too much potassium because it's potassium sparing. So you can run into hyperkalemia. Some examples will be spironolactone or aldactone and triamterene or direnium. Side effects, we just talked about it, hyperkalemia, and especially if the patient is taking a potassium supplement, you need to be careful with that because that can cause them to go into hyperkalemia. Nausea, vomiting, diarrhea, and anorexia, so make sure to take this with foods. You can have weakness and dizziness, headache, rash, and photosensitivity. With your potassium sparing diuretics, you want to make sure to educate your patient on avoiding salt substitutes and potassium-rich foods because, again, they're going to keep that potassium. So salt substitutes usually have a lot of potassium in them, and then obviously potassium-rich foods, you want to avoid that. Nursing considerations for diuretics. So you want to monitor the blood pressure because they're losing so much fluid and it can cause them to have hypotension. You want to, for your lab values, you want to assess kidney function and urinary output. You want to do this before initiating therapy and while they are receiving this therapy. Urine output needs to be at least 30 mLs per hour before you start diuretics, because if the body's not making enough urine to get rid of, then these diuretics are not going to work. You want to monitor for dehydration, hypovolemia, and orthostatic hypotension, because again, we're getting rid of all that fluid. It can cause some hypotension. Monitor your lab values, so potassium, calcium, sodium, and magnesium. You want to weigh them daily because that's going to be the most accurate way that you can assess whether or not this is helping get rid of that extra fluid. And remember, 1 kilogram is 1 liter of water, and that is equal to 2.2 pounds. So you can kind of figure out how much weight the patient has lost and convert that into how many liters of fluid that the patient has lost. You want to monitor their I's and O's, assess for edema, heart sounds, and breath sounds. Edema, because you want to have a baseline, because if the diuretics are working, then that edema is going to go down. Your heart sounds, you don't want any kind of sounds like there's fluid around the heart or any kind of dysrhythmias, especially if your patient has the risk of going into hypokalemia and hyperkalemia, because we know that potassium affects the heart rhythm. And then also breath sounds, you want to pay attention to whether or not the patient has like fluid on their lungs, so crackles, anything like that. Excuse me. You want to have a urinal or a bedpan readily available, especially on your patients that are a fall risk, or might have a lot of tubes hooked up to them, because when they have to go to the bathroom, they have to go, and it's almost immediate, and it's very often. So you want to make sure that those are readily available to you and the patient. You want to assess their ability to ambulate to the bathroom, again, so you want to know if they're a fall risk. If they are a fall risk, then you need to get a bedpan or you need to get a bedside toilet. You want to administer the diuretics in the morning, and that's because they're going to be urinating, diuresing all of this extra fluid off. So if you give that to them in the middle of the night, or if you give it to them before they go to bed, they're going to be up throughout the night, and that's going to be a fall risk because it's dark and they're sleepy. So make sure you administer the diuretics in the morning. And then you also want to monitor blood glucose, and especially in your patients that are diabetic. Next, we will briefly touch on your antihyperlipidemics. We won't get too in-depth on this. We will save that more for like your GI chapters and maybe 203 or 204. But I do want you guys to be familiar with these in case you come into contact with them at clinical or practicum. So we know that hyperlipidemia is excess of one or more lipids in the bloodstream, and you've got different types of lipids. So your high density or your HDL, low density LDL. Your low density is going to be the lethal. So low density lethal, that's the bad cholesterol, and you want this low. LDL is going to be one of your risk factors for developing atherosclerosis and heart disease. Your high density, so you want your high density healthy, H&H, that's the good cholesterol, so you want that one high. You want your LDL low. There's also very low density, or VLDL, and then your triglycerides. The reason that we are talking about these antihyperlipidemics, because usually with a patient that is taking blood pressure medicines, usually they'll have an antihyperlipidemic with it, because that's going to help improve that peripheral blood flow and decreases the risk of heart disease. Different types of antihyperlipidemics. We've got your bile acid sequestrants, fibrates or fibric acid, niacin, cholesterol absorption inhibitors, HMG CoA reductase inhibitors or statins, and then there's combination drugs that kind of combine different types of those antihyperlipidemics into one. Here is a chart, and this basically just splits it into the types of your antihyperlipidemics and then names of them. So your, for example, bile acid sequestrants, you'll have your cholestyramine. That's going to be a common one that you'll see. Your fibrates, gemfibrozole, you might see that one, or fenofibrate. Niacin, it's also known as nicotinic acid or B vitamin, you might see that. Cholesterol absorption inhibitors, ezetimibe or Zetia. That's really the only one that we'll talk about. And then you've got your HMG CoA reductase inhibitors, or they refer to them as statins because the end of the drug name is a statin. So atorvastatin, fluvastatin, lovastatin, pravastatin, simvastatin, and rosuvastatin. So you will probably come into contact with a statin. How these work, and they work a little bit different. Each category works a little different in the body, but in general, they will lower your cholesterol, helps prevent atherosclerosis, and decreases that risk of cardiovascular disease. Side effects, it's going to be your GI upset, because it's usually these are supplied as oral forms. So your abdominal pain, distension, cramping, and flatulence. For niacin specifically, there is a a side effect of flushing. So the patient might get red and hot. Have the patient take an aspirin about 30 minutes prior. This will help reduce that flushing if it becomes a problem. You also want to watch blood sugar in your patients with diabetes that are taking niacin. For your statins, a rare adverse effect is going to be rhabdomyolysis. And this is the breakdown of muscle tissue, and it releases a damaging protein into the blood, and then that protein can damage kidneys. This is very rare, but it is an adverse effect of statins. So make sure that you're paying attention to patients' muscle tone, kidney function, everything like that. Nursing considerations. For patients that are taking cholesterol medicines or antihyperlipidemics that are also on warfarin, you want to monitor their PT and INR, because specifically with fibrates, this can potentiate the effects of warfarin, so they are at a risk for bleeding. You want to monitor liver function because these are metabolized in the liver, and most of these are not going to be safe in pregnancy. So pay attention to that if you have a patient that is a woman that is in childbearing age and they are being prescribed an antihyperlipidemic. It's not safe in pregnancy. Next category we will talk about is antianginal drugs. So this is anti-chest pain drugs, but we'll call them antianginals. First, we need to talk about angina pectoris. This is the chest pain, so acute cardiac pain, and it's caused from inadequate blood flow to the myocardium, or the heart muscle, and it can be from plaque occlusions or spasms of those coronary arteries. The decreased blood flow to the heart causes a decreased amount of oxygen to the myocardium, and that leads to that pain. Different types of antianginal drugs. You're going to have your nitrates, your beta blockers, your calcium channel blockers, and I didn't put it on the slide, but morphine, and it's an analgesic, but morphine can also help with chest pain. So nitrates work in the body. They relax the smooth muscle of the blood vessels. This decreases the workload of the heart and promotes vasodilation. So basically it makes the blood vessels bigger, and it's easier for the blood to pump through the body. Generally, it causes vascular and coronary vasodilation, which increases blood flow through the coronary arteries to the myocardial cells. So if we can think of blood vessels as a water hose, basically what the nitrates do is make the water hose bigger. Examples of nitrates that you will often hear is nitroglycerin. You might also see it as NTG. There are different types of nitroglycerin. So nitrobid is going to be an ointment. Nitrodur or transderm nitro, that's going to be transdermal. And then you have your nitrostat, which is going to be sublingual. And then another type of nitrate is isosorbide mononitrate or dinitrate. Your dinitrate is going to be more of a long-acting one. Side or adverse effects, your main one, especially with sublingual nitroglycerin, is going to be headache. That's what a lot of your patients are going to complain of. So if you have a patient that comes in with chest pain and the provider orders nitroglycerin, and we'll talk about more how nitroglycerin works with your coronary artery disease PowerPoint. But basically, you'll give them the sublingual nitroglycerin, and they might complain of a headache. And that's not really a normal side effect, but it's a fairly common side effect for your nitroglycerin sublingual. There can also be a risk of hypotension, so you probably don't want to give nitroglycerin to your patient that has a low blood pressure already. Dizziness, fainting, and weakness, that has to do with the blood pressure. Burning or tingling, this is going to be more for your sublingual. When they have that under the tongue, you can usually tell them if it's burning or tingling, that means the medicine is dissolving. So that is a good sign, but it's also a side effect. And then for your transdermal, that's going to be contact dermatitis, so they might have a rash with that. Drug interactions. So your antihypertensives, alcohol, and narcotics, these can all enhance the hypotensive effect of nitrates. So you want to make sure that if your patient is taking blood pressure medicine, you watch out for that blood pressure because it can drop it. Also, heparin and aspirin, if they are taking heparin or aspirin, it can increase their risk of bleeding if they have nitroglycerin. For your nursing considerations, nitroglycerin decomposes when it's exposed to heat and light. So your nitroglycerin, whether it's sublingual or it's IV, it's going to be in, I know specifically for your sublingual nitroglycerin, it's going to be in like a brown glass container. It's really small, probably like the size of your thumb, maybe smaller than that. You want to make sure to keep those nitroglycerin tablets in there because if they are exposed to light, it can break them down. Also, if you ever have to give nitroglycerin IV, you want to make sure that it comes in a glass bottle, usually, and you'll want to get one of those brown bags to, not like a brown paper bag, it's a brown plastic bag, but basically you want to put that over the nitroglycerin so those lights don't affect it. There's also special tubing that you'll use with nitroglycerin IV, again, and that's just to keep it away from that light. If the patient has sublingual pills at home, which a lot of your patients that have a history of heart attack or coronary artery disease, they will have sublingual pills at home. You want to make sure to educate them to replace those every 3 to 6 months. I've had multiple patients come into the ER and say, yeah, I have nitroglycerin, I've had it for 3 years. Well, that's not going to do anything for them because the medicine is already, it's expired and it's not going to help. For your nitroglycerin sublingual, so usually if a patient is having chest pain, they will either take at home or we will give them to them in the ER some nitroglycerin sublingual. The way that works is they take one nitroglycerin sublingual and then let it dissolve, and then in 5 minutes come back, check on them. If the chest pain is still there, then we give them another nitroglycerin sublingual. And you can do this 3 times. If the pain does not subside after 3 nitroglycerins and maybe they're at home, they need to call 911 or they need to go to the ER immediately. Make sure that before you give your patient nitroglycerin, you take their blood pressure because, again, it is a vasodilator, so it will drop that blood pressure. You want to make sure the sublingual dissolves completely before giving them a new one. For your transdermal or the ointment, you want to rotate sites and make sure that when you take a transdermal patch off or the ointment, you wipe it off completely. So you want to get an alcohol swab and wipe that ointment or any residue left over off completely because that can still be metabolizing on their skin. You don't want to rub or massage the ointment into the skin. You want to apply it to a hairless area. Make sure to wash the medication off of your hands if it gets on your hands or the patient's hands. But especially make sure you wear gloves when you're administering nitroglycerin because it can be absorbed through the skin. So even with those sublingual pills, you want to make sure to drop that into like a medicine cup or the lid of the nitroglycerin bottle or something because you do not want that to get on your skin because it can be absorbed by you and then you can have the hypotensive effect of it. And also remove old patches before applying new ones. Nitroglycerin, you probably want to take it on an empty stomach. Avoid stimulants with nitroglycerin, so caffeine, nicotine, etc., because that's going to just cancel out what the nitroglycerin is doing. And the more that the patient takes nitroglycerin, the more they will develop a tolerance. So they might start out with 1 nitroglycerin sublingual will help with their chest pain. The more that they take that, they might have to move to 2, and then they might have to move to 3. So they develop a tolerance to it. Here is, for you visual learners, a picture of nitroglycerin. It kind of just tells you about nitroglycerin. So it says we need to blow this tunnel open and widen it for better access, send up the nitroglycerin. So it makes the tunnels wider, or the blood vessels wider. Your rapid administration, meaning that they get into the system rapidly, your sublingual nitroglycerin IV or your translingual spray. For slower acting, you have the transdermal patch, the nitro ointments, or the sustained release capsules. And you want to make sure that you watch out for hypotension, tachycardia, dizziness, headache, and syncope. Next, we will talk about beta blockers. So beta blockers, these work in the body, and they work for specific things in the body differently. So I have it under antianginal, but we will also talk about it when we talk about heart failure, and we will also talk about it when we talk about antihypertensive. So beta blockers work different ways depending on what's going on with the patient. So for heart failure, for chest pain, the beta blockers work as an antianginal. They decrease the workload of the heart, which decreases oxygen demand. So if the heart doesn't need as much oxygen, or if it has a good supply of oxygen, that's going to decrease that chest pain. Examples, you can have labetalol, propranolol. So these are going to end in OLOL. So you can see that picture down there. And again, we'll talk more about this during the antihypertensive drugs. Your side and adverse effects, your beta blockers are going to decrease heart rate and blood pressure. So you definitely do not want to give a beta blocker if the patient's heart rate is already low. Usually if the heart rate is below 60, you'll hold the beta blocker. Now it's going to be different for each patient, different for each facility, different per each doctor. Sometimes it's 50, sometimes it's 60. So make sure that you know when you're administering beta blockers when you need to hold that beta blocker. For your people with asthma, beta blockers can cause a bronchospasm. So when you're assessing, you want to check their lung sounds. If they have audible expiratory wheezes, or if you hear wheezes when you're listening to their lungs, that might indicate a bronchospasm. So you need to let the doctor know, maybe administer some oxygen and stuff like that. Also, beta blockers can have a behavioral or psychotic response. So people can kind of go through some psychoses. And then it can also cause impotence in your men. Nursing considerations. Never ever abruptly stop beta blockers. Beta blockers, when you start beta blockers, they are started as a low dose and they gradually increase the dose. So that's how they need to stop taking beta blockers. They're going to be tapered down over 1 to 2 weeks. And this is to prevent the rebound effect. So if you abruptly stop taking beta blockers, the patient can have reflex tachycardia or cardiac dysrhythmias, and that's not something that we want. So make sure that you educate them on not abruptly stopping those beta blockers. Also, rise slowly when sitting up or standing up because of that risk of hypotension. And before administration, every single time before you administer a beta blocker, you want to assess the apical heart rate. And you guys should know exactly how to assess the apical heart rate because you've had that in assessment. Our last antianginal drug that we will talk about is going to be your calcium channel blockers. These decrease the workload of the heart and decrease oxygen demands. So we know that calcium in the body causes myocardial contraction and increases the workload of the heart. So your calcium channel blockers do the opposite. They're going to relax those arteries and decrease oxygen demand, which is going to reduce the workload of the heart, right? Examples, you can remember calcium channel blockers as very nice drugs, VND, so verapamil, nifedipine, and diltiazem. You might also hear amlodipine, And any drug that ends in pine, or I say it as pine, you can say amlodipine, amlodipine. It really just goes by where you're from and how you say it. But usually your medicines that end in pine are going to be calcium channel blockers, except for those the verapamil and diltiazem. Those you kind of just have to remember. But if you say, remember calcium channel blockers, very nice drugs, verapamil, nifedipine, and diltiazem. Side effects are going to be headache, hypotension and bradycardia, dizziness and lightheadedness, that has to go with the hypotension, nausea, diarrhea, or constipation. They can have flushing of the skin, reflex tachycardia from hypotension. So if the patient gets hypotensive, the body is going to compensate by increasing that heart rate. Peripheral edema, and then also changes in liver and kidney function. Nursing considerations for calcium channel blockers is you want to make sure to assess your vital signs before administration, especially that apical heart rate. You don't want to chew or divide any kind of sustained release calcium channel blocker if it comes in a sustained release pill. Change positions slowly, getting up from the bed, sitting to standing. It can cause drowsiness or dizziness, so make sure you educate the patient that they don't need to drive until they know how calcium channel blockers are going to affect them. So if they're newly prescribed calcium channel blockers, they need to figure out how this affects them. If it makes them drowsy or dizzy, they don't need to be driving. You don't want to stop these abruptly because it can also cause that rebound tachycardia. And then the calcium channel blockers can increase toxicity of digoxin. So be careful with your patients that are taking digoxin and calcium channel blockers. Now we will move on to drugs for heart failure. The different categories we will talk about are cardiac glycosides, diuretics, beta blockers, angiotensin converting enzyme or ACE inhibitors, and inotropic agents. So if you look on here, we have already talked about diuretics and beta blockers, and the diuretics were their own category, and then beta blockers were under antianginal. So it's important that you guys recognize that different drugs can be used for different things. It's not just this drug is specifically used for this. So it's important that you guys know how they work in the body and what they can be used for, because it's not just a straight cookie cutter, diuretics work for this, beta blockers work for this, and only this. First, we will talk about cardiac glycosides. We'll focus on digitalis or digoxin. Digitalis and digoxin are the same thing. You might hear them referred to as either one. There's 3 different ways that digoxin works on the heart muscle. It strengthens cardiac force and efficiency, it slows the heart rate, and it increases circulation, which affects the kidneys, which increases diuresis. Digoxin can also be used for AFib or a flutter because it helps slow that heart rate. Side effects, your adverse effect, your main one is going to be digitalis toxicity. So digoxin has a long half-life. It's about 30 to 40 hours. So building up of digoxin in the body can easily occur. Some signs that you want to look for digitalis toxicity is going to be anorexia, diarrhea, nausea, vomiting, bradycardia, PVCs, and we'll talk about PVCs more in our cardiac dysrhythmia lecture. And then cardiac dysrhythmias is also a sign of digitalis toxicity. Headache or malaise. They can also have blurred vision and visual illusions, so they might see halos around objects. And then confusion and delirium. So you definitely want to be assessing your patient that is taking digoxin for digitalis toxicity. because if they go into any kind of cardiac dysrhythmia, it can be life-threatening. Nursing considerations for digitalis or digoxin. You want to make sure to take the pulse for 1 full minute and using the apical pulse. Hold your medication if the pulse is less than 60. And again, this is usually for your beta blockers, calcium channel blockers, ACE inhibitors, anything like that. Any kind of medicine that affects the heart rate, if your heart rate is already low, if it's already bradycardic, you probably don't want to give that medicine because it's just going to drop it lower. Your therapeutic digoxin level is going to be 0.8 to 2, and they will get blood draws relatively often to kind of watch out for that level. The antidote for digoxin is digoxin immune fab, so that's pretty easy to remember. Digoxin is a pregnancy class A, so it is safe for pregnancy. You want to make sure to monitor potassium because, again, we go back to those diuretics. Hypokalemia can increase the risk of digitalis toxicity. So your patients that are taking digoxin and diuretics, especially loop or thiazide diuretics, you want to let them know to consume foods high in potassium. And even if they're not taking diuretics, you still want to encourage that they take those foods, eat those foods high in potassium, because that's going to avoid that hypokalemia, which can throw them into digitalis toxicity. You want to weigh them daily and report a weight gain of 2 pounds or more, because if you have a weight gain of 2.2 pounds, that is 1 kilogram, which is also 1 liter of fluid. So you want to weigh them daily, make sure that this is effective for treating their heart failure. So we have already talked about diuretics, but we'll touch these again briefly. Diuretics help with heart failure because heart failure is when the body or the heart, there's too much fluid, the heart can't pump all that fluid out, so your diuretics help with getting rid of that extra fluid, making it easier for the heart to beat. Action of loop diuretics. It's going to reduce that blood volume, leading to reduced peripheral edema and pulmonary congestion. These are usually, your loop diuretics are going to be used in acute heart failure because, again, remember, these have the greatest diuretic effect. So your loop diuretics are going to be used in acute heart failure. Your examples are bumetanide, furosemide, torsemide. We talked about those. And again, you want to make sure that you administer these in the morning to prevent nocturia. Monitor for electrolyte depletion, especially potassium. And for your furosemide, you want to make sure and check that they don't have a sulfa allergy. Your thiazide diuretics, these work by blocking sodium and water reabsorption in the kidney tubules. These are going to be used in mild to moderate heart failure, and they're safe for long-term use. So this is kind of what patients will go home on if they have mild to moderate heart failure. Your examples, chlorothiazide or hydrochlorothiazide, HCTZ. Nursing considerations for thiazides, again, monitor potassium levels. Monitor for dehydration, hypovolemia, or circulatory collapse. Their sodium intake should be no more than 4,000 milligrams daily. And this is more so related to the reason that they are taking this medicine, and it's because they're in heart failure. So remember, wherever sodium goes, water goes. So you want to limit the amount of sodium so that you are also limiting that excess water in the body. Weigh them daily. You want to report a weight loss of more than 2 pounds in a week. Report fatigue or muscle cramping, and change position slowly to avoid that orthostatic hypotension, dizziness, so forth. Here is a little infographic on hydrochlorothiazide or HCTZ. So it is used to lower that blood pressure. It mobilizes edema and heart failure. Make sure you keep an eye on the electrolyte balance. Causes that hypokalemia, hypochloremia, hyponatremia, hyperglycemia, dehydration. So this is for our visual learners. Beta blockers, again, we've talked about these. I'll hit these a little bit more. How they work in heart failure for your heart failure patients. Basically, they block the cardiac actions of the sympathetic nervous system, so your fight or flight. So they block that action, and that's going to slow that heart rate down, and that helps reduce blood pressure. It decreases the workload of the heart. Your examples of beta blockers, again, they end in LOL or OLOL. Some of them might be ALOL or ILOL. Tenolol, metoprolol, propranolol. Nursing considerations. You want to start at a low dose and gradually increase every 2 weeks. You want to monitor blood pressure and pulse. If the pulse is less than 60, you want to hold the drug and contact the provider. Monitor your I's and O's, weigh them daily. Again, they don't need to stop taking this abruptly because it can cause that rebound effect. And if they are diabetic, make sure to monitor their blood sugars. ACE inhibitors, angiotensin converting enzyme or ACE inhibitors. You can remember these, they end in pril. So you've got benazepril, captopril, enalapril, fosinapril, anything ending in pril. These work in the body. They dilate venules and arterioles. That helps improve renal blood flow and decreases blood volume. So these really work in the kidneys. It also helps to release aldosterone, which this helps reduce sodium and fluid retention. So your ACE inhibitors work a lot in your kidneys. Nursing considerations for ACE inhibitors. These can increase potassium levels, so you want to monitor lab values. These are contraindicated in pregnancy, lactation, and a history of angioedema. A main side effect that you will see with ACE inhibitors is they can cause a constant non-productive cough. And sometimes this can affect the patient so much that they will have to switch medicines. Sometimes this is just a side effect that the patients can tolerate, so it kind of varies. But it can cause that constant non-productive cough. With ACE inhibitors, it can take weeks or months for the maximum therapeutic response. And again, you want to restrict sodium and restrict potassium. That will help with that fluid retention. And also, it'll help avoid the hyperkalemia. The last drug for heart failure that we will talk about is your inotropic agents. The examples of these are going to be dobutamine or dopamine. Action, they dilate renal blood vessels, and this helps stimulate blood flow through the kidneys, leading to sodium and water excretion through the urine. So these also work in the kidneys, and it helps get rid of that excess water. Side effects are going to be dizziness, nausea and vomiting, a headache, extravasation, and that's if they're receiving it IV, and then tachycardia, bradycardia, angina, palpitations, and hypotensions. Nursing considerations for your inotropic agents. You want to make sure that the patient is not taking MAOIs, tricyclic antidepressants, phenytoin or dilantin, or haloperidol or Haldol. These interact with the inotropic agents. And you also want to make sure that you are recording accurate I's and O's. So I'm going to stop the recording here, and I'm going to start a new recording over the rest of the cardiac medicines. So this is just part 1 of your cardiac meds. Make sure that you go and you watch part 2.